Welcome. I'm Ingrid Scheffer. I'm President of the Australian Academy of Health and Medical Sciences. And firstly, I'd like to thank you for joining us for our first online Life as a Clinician Scientist event in the midst of the COVID-19 pandemic. I would like to begin by acknowledging the traditional custodians of the many lands upon which we meet, acknowledging that individuals are joining us from around the country and indeed the world. The Indigenous peoples of Australia were the nation's first scientists. They remain the spiritual and cultural custodians of their land and continue to practice their values, languages, beliefs, and knowledge. I pay respects to elders past, present, and emerging, including emerging clinician scientists, and acknowledge any Aboriginal or Torres Strait Islander peoples joining us today. Let me tell you a little about the Australian Academy of Health and Medical Sciences, which is the nation's learned academy for health and medical sciences. We provide an impartial, authoritative, cross-sector voice of health and medical science in Australia, an independent, interdisciplinary body of 398 fellows elected by their peers for outstanding achievements and exceptional contributions to the health and medical science landscape in Australia. Collectively, our fellows present an independent voice through which we engage with the community, government, and industry. The Academy is uniquely positioned to convene cross-sector stakeholders from around Australia to address the most pressing health challenges facing society, such as the one we're facing today. Our fellows come from all fields across the health and medical sciences. Many are clinician scientists, and many of them are playing a pivotal role in the pandemic, and some of them have become household names through the pandemic. And we are keen to share their experiences with you. So our webinar is called Life as a Clinician Scientist, and it's our 5th year of running these webinars, which have been state-based, and the aim is really to showcase what life as a clinician scientist is about and how it brings together the best of two careers, both worlds, to make for a very exciting career. We have the benefit of an internet online event today, which allows us to reach a broader audience with more than 400 registrations so far. We aim these events at junior doctors, registrars, fellows, students, medical students, science students, allied health students, trainee health professionals, science researchers, anyone who wishes to become involved in research. And it's intended to support you to develop the skills necessary to succeed in combining clinical practice with medical research. So today we're bringing you the prep and the pivot, responding to a pandemic as a clinician scientist. And we've got some of the world's leading clinician scientists to tell you and me about their career paths and how they've developed, and then how they've had to pivot in 2020, how they've both been prepared for and responded to a pandemic, how they're working to try and find a potential cure, and how clinician scientists are driving societal change. I'd like to start by thanking our generous sponsors, Monash University, the University of Melbourne, the University of Queensland, the University of New South Wales, and the University of Adelaide. And we very much appreciate their support for this event. And most of all, I'd like to thank our very talented speakers who are going to tell us about their lives as a clinician scientist and then answer your questions after that. So before introducing Professor Louise Baur, who's the chair of our mentorship committee and the driver of this wonderful event, I'd like to ask you to use social media, #pandemiclax, lowercase pandemic, highercase lax, LACS, and they're going to show you this hashtag during the webinar. So it's my great pleasure now to introduce Professor Louise Baur, who is the chair of the mentorship committee, but also professor of child and adolescent health at Sydney Medical School, the head of the Children's Hospital Westmead Clinical School, and importantly, a consultant paediatrician at the Children's Hospital at Westmead. Louise is an internationally renowned childhood obesity researcher, and her interest is in the prevention and management of child and adolescent obesity, with 25 years of work in this field and also in adult obesity. She's been key in raising the profile of childhood obesity as an important issue of clinical and public health importance in both Australia and internationally. And of course, Louise is a fellow of the Australian Academy of Health and Medical Sciences. Thank you, Louise.
Thank you very much. Thank you very much, Ingrid. And welcome to all of you here on our webinar. We're thinking that we've had at least 400 people who've said that they were going to come. So that's tremendous. So this is the PrEP and the Pivot, responding to the pandemic as a clinician scientist. Now, we're beginning today with each speaker, we have 3 of them, outlining their background and career progress and the path that led them to becoming clinician scientists. Each of our speakers will then discuss their unique experiences to date with the COVID-19 pandemic and how it has impacted on their work and how they're making a very real difference to the fight against this global threat. Now, after each speaker talks, there'll be 5 minutes for individual Q&A, and then at the conclusion of all the talks, you will have the opportunity to really grill the speakers with all those burning questions about the life of a clinician scientist and how you might also follow this path for around half an hour. We're looking forward to your contributions during this segment. Now, you can ask questions at any point by using the chat box on screen to write a question. You'll see that either on the right-hand side of the video or in a separate window. Other viewers can then upvote those questions by liking them, just as you would on social media. If you'd like to address your question to a specific speaker, please type that at the start. Now, we're delighted to be joined by our speakers who are going to provide a range of expert perspectives, and all are global leaders in their fields. Now, the first person is Professor Sharon Lewin. Sharon is the inaugural director of the Peter Doherty Institute for Infection and Immunity in Melbourne, which leads the work of the Australian Partnership for Preparedness research on infectious disease emergencies. She's an infectious disease physician and research scientist. Sharon's expertise includes strategies to cure HIV infection and antiviral therapy. Sharon's involved in several committees supporting and advising the government on the response to COVID-19, as well as being on NHMRC Council, and she's a fellow of the Australian Academy of Health and Medical Sciences. I'll hand over to Sharon now. Thank you, Sharon.
Thanks very much, Louise, and thank you to the Academy, and particularly Ingrid, for your leadership over this pretty tricky time in our lives. And a great opportunity, though, to tell the world what medicine and science can do. And for me personally, I love that everyone now knows what an R0 means and talks about epidemiology and knows what a difference between a virus and bacteria is. These are sort of things that I've been fantasizing about for many years. So I'm going to share my screen now and take you through a bit of my story leading up to this period of time, and then focus a little bit on what I've been doing and what actually really the Doherty's been doing with respect to COVID-19. I'm sure we'll have plenty of questions after. So I've been asked to talk about the PrEP and the Pivot, and when I began thinking about this for me personally as a clinician scientist, the PrEP probably started a good 40 years ago in my training as an infectious diseases physician and a virologist. And here's a much younger me in an awful purple suit. But anyway, I remember thinking that purple suit was great at the time. And I graduated from Monash University in 1986. I like marking that point in time because I spent my life working on HIV. And when I started medicine in 1981, we of course didn't know HIV existed. I did a fellowship, trained as a physician, FRACP, in infectious diseases, finishing in 97, and combined that with a PhD in virology, which was focused on HIV, of course. then did a postdoctoral fellowship, which was quite a formative period in my career. I worked at Rockefeller University in New York City, and I'll talk a little bit more about that. Came back and ran a lab for a short period of time at Melbourne University, and then was Professor Director of the Department of Infectious Diseases at the Alfred for quite a while, which I loved. And I think that was a period where I was the true clinician scientist, doing a lot more clinical work than I am doing currently. And 2014 took on the opportunity of running a new institute, the Doherty Institute, based in Melbourne, an unincorporated joint venture, University of Melbourne and Royal Melbourne Hospital, which has been very active in the COVID response. So when I started getting interested in infectious diseases, this was the big one. For me personally, it still is the big one. It was what we were all worried about in the 80s. And this is what global emerging and re-emerging infectious diseases looks like in 2017. And this doesn't even have coronavirus there. So a pretty interesting period of time, 2 or 3 decades in infectious diseases. And back in the 70s, in fact, people thought infectious diseases was a dead specialty. There was no point in training more infectious diseases physicians. And of course, how wrong they were back then, and what an exciting area of work this has been for me over the last 3 decades, but particularly exciting now. And in my own area of HIV, we've of course seen HIV dramatically transform from a universal death sentence. And I love showing this slide, especially when I'm speaking to medical students or junior doctors, a very familiar image to many people my age of the Grim Reaper and what HIV was in the 1980s. And many, of course, young doctors aren't even familiar with this image. And of course now there's dramatic changes that we've seen, largely driven by science, but also very much driven by advocacy from the community to have fantastic treatments widely available across the world, fantastic prevention strategies, but still no vaccine and cure. And my work has largely focused on many aspects of understanding HIV pathogenesis, but over the last 2 decades, primarily on HIV cure. So I thought I'd just talk about a few formative experiences in my career which really changed my path. And this is another much younger me, wearing an Alfred Hospital coat, I note, in a hospital in Kenya. I took a year off between after my 2nd year residency and started, worked in a small mission hospital just out of Nairobi. It was just the beginnings of becoming aware of the scale of HIV across sub-Saharan Africa. And that period of time, a year working in that environment, which was fascinating, really kind of taught me, really shaped my view on what I wanted to do in respect to global health. And also made it very clear to me that I probably wasn't the person that was going to be at the front line in the back blocks of sub-Saharan Africa working, but wanting to do research that had a big impact globally. The other big formative experience for me was my postdoctoral period in New York. I had the opportunity, in fact, to work for David Ho. David was Time Man of the Year in 1996 for the discovery of antiviral therapy. And when I arrived with my family and 2 young boys in New York City in 1997, it was just the beginnings of treatment for HIV, when people thought that antiviral therapy was a cure. Within about 6 months, it was rapidly discovered that antiviral therapy is not a cure, and that's because HIV, just like many other viruses, COVID not included, establishes something called latency, a long-lived form. And I've continued my work on HIV latency since that time. Just an interesting anecdote, David has now become very active in COVID-19. So shortly after, back in February, the Doherty received a philanthropic grant from the Jack Ma Foundation. In China, they funded 2 groups outside of China, the Doherty and David Ho. And so 20 years later, I've reconnected with David. In fact, every Saturday morning at exactly this time, he and I and 2 colleagues, one in Beijing and one in Hong Kong, meet, talk about what's happening in each of our cities, talk about what's happening in research and what we can do together in response to COVID-19. So an incredible closure of this circle that started back in 1997. The other very formative experience for me in my career has been my involvement with the International AIDS Society, which is the largest professional society representing all people working in HIV, has about 14,000 members. And I had the opportunity to co-chair their annual conference in Melbourne back in 2014. And what I've learnt through my work with the International AIDS Society is the importance of community engagement, advocacy and leadership when you're dealing with a major global pandemic. And that is what has led to the success of HIV. It is the science, but it's also been this connection that HIV has been able to make with communities and politicians over the last 40 years. And for me, that is really, really relevant to what we're now seeing with COVID. COVID is a biomedical challenge, but the impacts of it are huge, economically, socially, globally, and the solutions will come from the science, but will also come through political leadership. So that's shaped very much my thinking in response to COVID. And my research, I still remain a very active researcher, despite a busy leadership role now. This is my group based at the Doherty Institute. Our work primarily, as I mentioned earlier, focuses on finding a cure for HIV. I'm very, very interested in fundamental virology of HIV latency, understanding why the immune system is dysfunctional, and then combining those to test strategies to eliminate latency or strategies towards the cure, what I call experimental medicine. And again, this is strikingly relevant to COVID-19, and you may hear more of this perhaps from Steve. You know, COVID-19 is a disease, is a virological disease. We need to stop virus replication, but it has this extraordinary impact on the immune system, meaning that interventions target the virus and the immune system, and there's a long track record of this approach in how we manage HIV. And I've also had a long-standing interest in many other viruses, a lot of work on hepatitis B and particularly how it interacts with HIV, as well as CMV and others. So that's my kind of story until 2014, when I moved to take on a position as the head of the Doherty. And as I mentioned, it is an unincorporated joint venture. We have about 700 staff. About 70% of them work for the University of Melbourne and 30% Royal Melbourne Hospital, with a grand vision of improving health globally through discovery, research, treatment, prevention and cure of infectious diseases. And we're actually quite unique in the country, a multidisciplinary institute that brings together research, education, but most importantly, public health. And this is what put us in a fantastic position to respond to COVID-19 back in late January. The major themes we have focus on immunology, healthcare associated infections, virology and host pathogen interactions. But virology is a very big part of what we do. This is a photograph of two of our stars who work in the virus isolation lab in the high containment facility, which we have at the Doherty, or level 4. Including Julian Druce on the left and Thomas on the right. And Julian was instrumental in isolating the first virus outside of China back on January the 29th. So in many ways, the Doherty was very prepared for this kind of challenge. A, multidisciplinary, B, public health, right next to research, and C, a heavy focus on emerging infectious diseases, as well as other viruses that can very much inform our response, particularly HIV and influenza. And we've done and achieved quite a lot in our contributions to COVID-19. Here is Mike Catton and Julian Druce. They diagnosed the first patient in Australia. They were the first to isolate and share the virus outside of China back in late January, which was actually quite extraordinary. And we can talk more about why Australia was so well placed with testing because of this preparedness. We had testing up and running across the country by late January. We've had a very active role led by Jodie McVernon to develop mathematical models, which have been informing the Australian and Victorian government's response. Through the leadership of Steve Tong, we're leading the largest national trial of antivirals for hospitalised patients, working close contact with Steve Webb, who looks after patients in ICU. This trial is one for hospitalised patients. And we have 4 vaccine candidates and some very interesting work on COVID-specific antibodies, which are in preclinical development. So the whole institute has very much pivoted to bring a lot of expertise across a range of disciplines to COVID-19, as is the case, I think, for many institutes right now in August of this year. Another aspect of being prepared was at something called APPRISE. This is a NHMRC CRE that I lead. It's the Australian Partnership for Preparedness Research of Infectious Diseases Emergencies, a major mouthful, and I always forget what the acronym actually means, but it's called APPRISE. It extends across Australia with about 19 lead investigators, 20 institutions, and extensive links to national and international research networks, and has actually doubled in size over the COVID pandemic. We've had a big focus on sharing data, work in key populations, Indigenous health, public health, ethics, laboratory research, and clinical research. And because we've been up and running since 2016, we, as a network, were very well placed to respond to COVID-19. Actually, back on January the 13th, we activated the first observational clinical trial of people with COVID. And so this network certainly has made us prepared across Australia in the public health clinical research arena. What's the pivot to COVID-19 meant for me? Well, actually, my main role has pretty much been, I think, in leadership, certainly leadership across the Doherty, given the scale of the response, leadership across for APPRISE, which now includes over 50 investigators, and a national leadership that Louise had mentioned, largely around policy development through something called the National COVID Health and Research Committee, or NCRAC, which Ingrid and the Academy is a key member of. I've had a very strong passion and involvement in engagement, and I think this very much comes from my HIV background. I've been very active in science communication. I think it's really important, and particularly important in a time of crisis, for the public to understand what all this science means and what science can do. And I've had a very active engagement in philanthropy. The generosity of Australians personally and through large business has been extraordinary, and they've supported much of the work that we've been able to do quickly at the Doherty. I am, though, at heart a nerdy virologist. So I have watched what's going on, desperate to actually do more. And of course I am, but not at the level that I probably would like to do if I wasn't director of a large institute. About 30% of my lab have actually pivoted to COVID. I've got about 20 people in my group, and many of them have expertise in high containment virology, working in a PC3 environment. Pretty unique skills. That's what my lab does. And so a third of them have moved to COVID, which I'm very proud of. Our focus has been predominantly on improved diagnostics as well as pathogenesis for COVID-19. I won't go into the scientific details. I've played a very important mentorship role for particularly Irani Thevarajan, who set up a very important COVID biobank, and my lab, clinical research lab, because all clinical research was effectively stopped in HIV, we now support collection and storage of samples for COVID. And I've been very active in the antiviral clinical trial domain of a national study called ASCOT, again, bringing some of my expertise and contacts in antivirals to the COVID space. Just very quickly, some personal challenges. Maintaining a hopeful message, particularly in Victoria right now, is certainly a challenge, but really, really important. We will get out of this, but maintaining a hopeful message without over-promising. Managing uncertainty, especially with young staff. Even if you're not in Victoria, COVID has disrupted us economically and will disrupt the face and future of science. Supporting colleagues at a tremendously difficult time, especially healthcare workers, which we're experiencing right now in Victoria. Taking time off, very challenging when you're working at home and all the lines blur. I'm sure something that everyone shares. Maintaining a routine for me when I've never had one. Every week seems to be the same. There's nothing punctuating the Groundhog Day experience, again, what everyone's feeling. And for me, I have a bit of sideline guilt. I read this fantastic opinion piece in JAMA on sideline guilt. You know, coming from people that aren't working at the front line. You know, I still see outpatients, but I'm not active in the inpatient ward service. And there's a feeling of guilt of not actually working, looking after patients with COVID-19, which I suspect many clinicians feel. But I was really reassured by the final words from David Rubin. He wrote, "The crisis will pass, and the next generations will ask us what we did during the COVID-19 pandemic. Some, like Steve Webb, will tell of the intensity of directly caring for patients. Others, like me included, will say, I was there and I played a part." And so I think all of us, no matter what your background, virology, clinician, public health, or anything else, we will all continue to play a part. So just I want to acknowledge all of my colleagues. This is a Zoom call that we held daily for the first 3 months of all the leadership across the Institute, now twice a week. And to shout out to the thousands of COVID heroes at the front line, but also those on the sidelines too. Thanks very much.
Thank you so much, Sharon. That was tremendous. We've got just a few minutes before we go on to the next speaker. I've had several questions asking about the successful practical strategies you found to balance your life and career as a clinician scientist while raising a family at the same time. They look like they've grown. Were those the guys at the end?
Yes, that was graduation last. Exactly, that's my little baby that was in the stroller, graduating from Melbourne University last year. My strategy's been that I'm committed to all three, meaning being a good clinician, being a good scientist, and having a normal life, and being a good wife, mother, daughter, friend, etc. And I think if I look back over my career, I don't think I've done all three of them equally as well or spent equal amount of time throughout my career. So I think just accepting that at periods of your career, you'll spend more time with family and have less time with work. I worked part-time for about 10 years, about 4 days a week, but it was still part-time. And then at times where your clinical work will be the absolute main focus, which was my period when I was director of a large clinical service at the Alfred, and periods where my research was, and I actually tell this to people, clinicians who take time off to do a PhD or a postdoc, and they're always itching to get back into clinical work. And especially when things are grim in the lab, it's really easy to run back to the clinical work. And I always tell them, you've got to put the time in for that research training, otherwise you'll never be successful and you'll never be taken seriously as a researcher. So I think it's not just balance, it's giving weight at different times of your career. And for me, that shift has changed a lot in different phases of my career.
Sharon, there was one other question I'll ask just now, but there were several questions related to leadership. So has it been easy for you to find leadership opportunities, especially early in the career? What advice do you have for medical students on this? And another one, what has helped develop your leadership skills?
Well, I trained in the 1980s. The kind of concept of leadership skills or mentorship didn't kind of exist. We just kind of bumbled through our training. It was really my recollection of life. But having said that, Louise agrees. Having said that, I was given a lot of leadership opportunities. I didn't actually pursue them. I've always just been passionate about science and medicine. And as I mentioned, I'm still a bit of a virology geek. I kind of love reading about new science. But I was given a lot of leadership opportunities. And I took them, maybe a bit reluctantly at the beginning, then really enjoyed it, and then realised I have got quite a lot to contribute through leadership. I think I've had a different experience to many women, and I know that. My mentors all along the way, many of them male, some of them, Graham Brown, Steve Westling, many others, were always really supportive and always just encouraging me to go for it, and never felt my being female was a barrier at all. But I know that other people have, many women experience that, and I do see it still now. So I had many opportunities. I had a lot of support to take them. I've also had many periods of uncertainty in leadership and not sure whether I was doing the right thing or doing it well enough or whatever. So I've always actually maintained very open dialogue with mentors, and I openly say that I have many mentors now. I will often ring certain people, Steve Wesley, one of them, saying, shit, I've got no idea what to do here. And people, you know, you've got to have colleagues like that, no matter how senior and experienced people look. Everyone has periods of uncertainty, and we're all, I mean, now, my God, you know, we're faced with challenges that none of us have dealt with. And so I'm a big believer in sharing those and maintaining, you know, those relationships with people who, you know, can provide very sound advice.
Sharon, that's fantastic. Such helpful, thoughtful, wise advice there and comments. We'll have to leave you now. We can pick up on some of those questions later on, but I want to now turn to Steve Webb. Steve is Senior Staff Specialist in Intensive Care at the Royal Perth Hospital and Professor of Critical Care Research at Monash University. He is working at the front line caring for COVID-19 patients in ICU. His research interests relate to the causes and management of immediately life-threatening illness, including influenza and pneumonia. He is Australian Principal Investigator on the REMAP-CAP trial, a randomised, embedded, multifactorial adaptive platform trial for community-acquired pneumonia, which involves more than 50 facilities in 13 countries. They're looking to understand which treatments might be most effective for patients with severe COVID-19 symptoms. Steve is also a fellow of the Australian Academy of Health and Medical Sciences, and I thank him for talking now. Thanks, Steve.
Thank you very much, Louise, for that generous introduction. As you said, I'm an ICU specialist, and I've also had the privilege of being someone who designs and conducts large-scale clinical trials. I've been involved in trials that have randomised perhaps 40 or 50,000 patients, and I've been fortunate enough that some of those trials have provided a clear direction about how to directly improve the outcome of patients with critical illness. I'm a passionate clinician and a passionate scientist. One of the things that I want to emphasise about why I'm so excited about being a clinician scientist is the effect modification and amplification that comes from being a researcher. As a clinician, I have the privilege of caring for patients, and it's a wonderful, special privilege. But as a researcher, I get the opportunity to generate evidence that can have a beneficial impact on so many more patients than I could ever see myself as a clinician. There are clinicians at the moment in countries all around the world applying the evidence that I've been involved in generating, and the benefit that flows through to so many more patients than you can ever see is what I think makes research special. I trained as an ICU specialist. I developed a fascination and a passion for research as a FRACP trainee because I loved reading the clinical trials and the research work that was cutting edge as a physician trainee back in the mid-1990s. And even while I was still completing specialist training, I started doing a Masters of Public Health and then undertook what was actually, for a clinical researcher, an unusual path. I did a basic science PhD at Imperial College, and I loved the broad education that came from that sort of background. And I came back to Western Australia and started to try and establish myself as a clinician scientist. There's a few sort of themes that I want to try and explore and cover. And the first of them is the importance of formal training. We don't question the need for formal training as a clinician, but as a clinical researcher, formal training in the methods of epidemiology, biostatistics, public health is, I feel, an incredibly important component. And it's tough as a clinician researcher in clinical research and clinical trials, because I think it's really important to have that core skill set in epi and stats, as well as undertaking a PhD. And so it's a doubly difficult pathway. But without wanting to quote Donald Rumsfeld excessively, there are known unknowns and unknown unknowns. And unless you've had formal training in epi and biostats, you don't know your unknown unknowns. And so having that foundational knowledge in the basic science of epi and stats is absolutely vital. And if you're a clinician, I want to focus on the absolute importance of clinical work. And I think this applies irrespective of whether you're a basic scientist or a clinical researcher. If you leave clinical practice, things change, styles change, what's important change, the epi of disease changes. And it's only by maintaining contact with patients with the diseases of interest that you maintain that vital link to patient care that gives your research context and importance. I still do quite a lot of clinical work. I'm a 0.6 FTE clinician, and I take no favours from the person who writes the rosters at Royal Perth. I do pro rata as much night and weekend work as any of my clinician colleagues, and I believe it's important to do so because in an intensive care unit, it's massively a team sport, and everyone has to do the same sort of work at the coalface. Some clinical specialties, it's possible to maintain clinical competence at much lower FTE, but surgeons, intensivists, other procedural specialists need to have a minimum of around 0.4 or 0.5 FTE to maintain clinical competence and to maintain their credibility with their colleagues, as well as make sure that they provide appropriately high quality clinical care. It was interesting to hear Sharon talking about the wonderful mentors that she's had, and knowing some of those names, I would know the wonderful advice that they've been able to provide Sharon. I started as a clinician in a specialty that didn't have a lot of academic history in the 1990s. It was a time of massive transformation in intensive care research, and I'll come back to that. But I really didn't have people that I could turn to give me guidance. And as such, I think I went down a few blind alleys that might well have been avoided by good quality advice. So seek out mentors, be discriminating, work out the mentors that can give you good and consistent advice, and then, as Sharon has done, hang on to them for a lifetime. When I came back to Perth, I had an initial academic appointment, and I'm a failed basic scientist. I tried to set up a lab, and labs are really difficult things to establish. There's sort of a critical mass that is necessary to make a lab work. And I worked incredibly hard to try and make a lab work. And when you first start out, the trajectory just above horizontal or just below horizontal is very, very subtly different, but one leads to a spiral of positive feedback and progressive improvement and building track record. And the other, irrespective of talent or hard work, lies just below the horizontal and leads to, unfortunately, a failure to progress and build that critical mass. And so I had an early pivot away from laboratory science and into clinical trials. And it was just at the time that the Australian New Zealand Intensive Care Society Clinical Trials Group was expanding very substantially. And there I found wonderful mentorship and wonderful opportunities. And at that time, I actually left academia. I went back to being a full-time clinician, and it was actually the best thing that I ever did. I stopped being worried about track record, and I focused on doing research that I wanted to do and working with people that I liked working with. And it was a wonderful recipe for what's turned into a fabulous amount of academic success. Research should be fun. It's not always fun, but it should have a basis in fun. We work enormous number of hours, and it's hard to put in those hours without passion and without feeling as though what you're doing is fun. The opportunity to discover new things, the opportunity to work with amazing colleagues can and should be fun. Academia is incredibly competitive, but there can and should be higher values than just your personal academic success. Sometimes there can be a tension between personal track record, academic success, and what's really best for the patients who might benefit from your research. And my strong advice is to, if there is tension between those two things, to always place the importance of patients first, because when you do that, your own academic success follows naturally, and there's no real compromise to be had. I think one of the things that I've acquired gradually is better vision. And vision's a difficult thing to describe. It's a difficult thing to learn or teach. But if there's something that I can try and impart about vision, it's to make predictions about the future, make predictions about where your discipline is going to move in terms of research direction, and be objective about whether or not your predictions turned out to be correct, so that you can best spot opportunities when they become available. I was very interested in what Sharon said about family life and balancing the competing requirements. And I would just add to that that both life and research and clinical care are long games. I think it's a trap to feel as though you're under pressure to deliver under short periods of time. And if you're strategic and you play the long game, which is about balancing those responsibilities with different priorities at different stages of life when they're important, you can actually have it all. And lastly, before I talk a little bit about the pivot to pandemic, I just want to emphasize the importance of being broad in your life. Have interests outside of medicine and outside of your research, and enjoy those aspects and gain satisfaction from them. But also, you'll be surprised how those skills, those relationships, those opportunities end up cycling back into your clinical work and your research to make you more effective. So the story of this pandemic for me really starts with the last pandemic. In 2009, a new strain of influenza, H1N1, emerged in Mexico in March, April. There was a little wave in the Northern Hemisphere, but it came to the Southern Hemisphere as a seasonal disease. And in May of 2009, we were starting to see a large number of patients being admitted to intensive care units, particularly in Victoria. And it was often young people, previously fit and well, who had life-threatening influenza. And I'll come back to this later, but in clinical research, it's infrastructure, not inspiration, that is king. Within the ANZIC's clinical trials group, we're in a situation to very rapidly gain approval and start commencing observational data collection in every intensive care unit in Australia and New Zealand. And that meant that we had a whole of population perspective on critical illness due to this new disease. And we aggregated that data quickly, and in something which is not, which is completely similar to the experience that we have at the moment during COVID. We closed for new recruitment on August 31st that winter. We allowed 7 days of follow-up. We locked the database 7 days after that, And 48 hours of furious writing later, we submitted a manuscript to the New England Journal of Medicine. It went through a very rapid review, and 2.5 weeks later, I was giving a plenary presentation at the European Society of Intensive Care Medicine in association with simultaneous publication of that study in the New England. And that played a pivotal impact for public health authorities in the Northern Hemisphere to be able to plan their response to the H1N1 influenza. When the dust settled for us and colleagues in different countries regarding our response to that pandemic, we were frustrated by not having been able to conduct and plan randomized controlled trials, which we regarded as our core business. And so in 2010, we started planning for the pandemic that came in 2020. And we developed a clinical trial called REMAP-CAP with a long and complicated acronym as outlined by Louise. But this was a trial that was pre-planned, pre-approved and practiced to be ready for if and when a pandemic emerged. So I can tell you exactly where I was sitting on January 17th when I received an email from Herman Goossens, who's the head of the European equivalent of the APPRISE consortium, indicating that there was clear evidence of sustained human-to-human transmission of this novel coronavirus in Wuhan, and we needed to start thinking about how we were going to pivot REMAP-CAP if this truly became a pandemic, as it has. At that stage, REMAP-CAP was recruiting in 13 countries at 50 sites. Since then, it's expanded to 250 sites in 18 countries. I need to define the term a domain, which will become apparent later, but a domain is a set of research questions within this type of trial, which is known as a platform trial. And in January, we had 4 active domains, and it had taken us 4 to 5 years to get those 4 active domains up and running. Today, we have 11 active domains and another 3 domains under construction. And we've taken what is probably the most complex clinical trial design that exists and have made it a reality during the pandemic. I won't belabor too much the design features in REMAP-CAP, but I think likely that this will broadly become the way that we do clinical trials in the future. Its unique design features are that it's multifactorial, and by that I mean we actually randomize the same patient to multiple different components of care, one component in each domain. And that creates substantial efficiency because we're asking multiple questions simultaneously. More interestingly, because we're randomizing multiple different aspects of care simultaneously, we can evaluate the impact of interaction between different interventions that are within the clinical trial. And that's a novel feature of clinical trial design. It uses Bayesian statistics, which means that we have no limitation with respect to the frequency and number of interim analyses that can be done. We just look at the probability that is generated from past data combined with new data, and that means that we conclude a question as soon as there's statistical confidence, not with a pre-specified sample size that may be an under or overestimate of the number of patients needed. And lastly, and for a clinician most importantly, we use a technique called response adaptive randomization to vary the proportion of patients being randomized to each intervention as the trial progresses, so that patients are more likely to receive better therapies inside the platform. It's not just evidence generation, it's simultaneous implementation of the results of treatment. So that's a massive global trial. It's led from Monash University, but it's supported by the NHMRC, the HRC in New Zealand, the CIHR in Canada, the NIHR in the United Kingdom, Horizon 2020 in the European Union, and in Australia and globally also through the Minderoo Foundation. And so it's been a remarkably busy 6 or 7 months. I was literally working 12, 14, 15-hour days for 3 or 4 months straight. Fortunately, or just as a consequence of exhaustion, we've been able to slow down a little bit, and we're now in a consolidation phase. We never knew whether or not a pandemic was going to occur, but we put a lot of work into the possibility, and we're now in a position to try and generate time-critical evidence. Thanks, Louise.
Thanks so much, Steve. Again, a really amazing insight into both how you become a clinician scientist, but also the specific issues that you've been dealing in relation to COVID-19. Just a couple of questions, Steve. We've had a number of them related to the issue of mentorship. How do you choose one? Can you go and choose one? How do you approach people to do it? Are there formal strategies for getting mentorship? Sharon talked a little bit about this, but maybe you could enlarge on that.
So the universities and the institutes now have quite sophisticated and thoughtful mentorship programs. The Academy itself runs a mentorship program which is designed at a very specific level of a researcher. So those are programs that exist and people can take advantage of them. Most of the mentorship that I received occurred through informal pathways within the ANZICS clinical trials group. Our country, Australia and New Zealand, are blessed with some of the best clinical researchers in intensive care in the world. People like Ronaldo Bellomo and Simon Finfer, John Myberg and Jamie Cooper. And I was incredibly fortunate to be a junior investigator and was able to learn from them both aspects related to leadership as well as the nuts and bolts of how you make sure that the big machine of a clinical trial can succeed. And so for those who are on the webinar who are in a discipline that has a clinical trial network, as well as clinician leaders whom you work with, university and institute people, your clinical trials network is a wonderful place to find possible mentors.
Steve, we'll have to leave that now with asking questions of you, and we'll move now to our next speaker, Ian Hickie. We'll ask some of these broader questions to the whole group. Ian Hickie is Professor of Psychiatry at Sydney Medical School and Co-Director of Health and of the Brain and Mind Centre at the University and an NHMRC Senior Principal Research Fellow. Ian is an internationally renowned researcher in clinical psychiatry and a leading voice on mental health issues. He was an inaugural Commissioner of Australia's National Mental Health Commission from 2012 to 2018, overseeing enhanced accountability for mental health research reform in Australia. He's now focused on the development of real-time personalised and measurement-based care systems for use in partnership with young people and their families. He's a fellow of the Australian Academy of Health and Medical Sciences. Thank you, Ian. Over to you.
Thank you, Louise, and thank you for the opportunity actually to talk about mental health in the context of the pandemic and its wider ramifications. The issue about being a clinician scientist, I think, couldn't be more important than right at the moment. And I think it does actually raise for all of us, as Sharon and Steve alluded to, the fundamental kind of both beauty of being a clinician scientist and the fundamental challenge that we face every day. So certainly starting my own career in psychiatry, the clinical medicine aspect of that is just incredibly grounding. And I think the importance of clinical scientists is that. They're people who are sitting there at the front lines. They're sitting with people, real humans in everyday life, whose lives are being affected by whatever particular illness or whatever particular circumstance they find themselves in. And they're also tending to see the wider social context, the impact of that on a person's family, the group they come from, how it is impacting their lives. I always get medical students to read the Samuel Shem book, House of God. You know, it's that idea you're going to fix everything, but actually you're quite vulnerable yourself. You don't know all the answers to the particular thing. It's a very important concept, I think, in there of actually being with people, even when you can't fix the problem. And I think that's what sort of grounds clinicians in the experience. And that remains very fundamental, and I think, in the human connection of that. But there's also the great frustration. I wish I could do it better. I wish I could fix the problem. And I think what both Steve and Sharon alluded to has been critical in my career, and certainly in mental health and clinical psychiatry, is, okay, this is what we have now, but what do we have in the future? At what level can we change not the individual treatment for the person we see being affected? What steps can we change, prevent this actually occurring in the first place? And I guess infectious disease has been a classic of that, and the success of vaccination and everything else, but also change the course through effective treatments. Steve alluded to something which is a great frustration in my life, which is the lack of infrastructure. So a lot of my life is tied up with health services. You know, and if you work in an area where mental health has traditionally been one that's been neglected in terms of its range of health services, then that is critical. A very famous psychiatrist internationally, Norman Sartorius, who's in his, if I say that he's late 80s and he's in his later years, if you're very annoyed with me, you know, he's still extremely active in his late 80s, suggests that every clinician take about 10% of the time out of their life to get involved with the public health or the politics, frankly, the politics of what they do, because they have that real life engagement with human the crisis, but they also have the great frustration of knowing it's got to be better. If we just keep doing what we're doing, we're not necessarily improving the situation. And I guess the course of my life very much has been, I just want to share a particular screen with you, a number of screens as we go, is being continuously told in my life, it won't happen. Actually, things do happen. And I think this was said to me by a great friend at the time, who I won't name, but it had to do with a particular fight that we were having at the time about covering psychological care in Medicare, which for younger Australians won't be aware that that was not the case before 2001 and not widely the case before 2006, an area that's included from our universal coverage. And why get involved in a fight like that? Well, whether something's funded, whether it's supported, whether the infrastructure is there, has big effects on what people are actually able to access. And the Goethe quote, which I particularly like, and again, I tend to use in a medical thing, is, you know, just having knowledge just ain't enough. You know, we have an obligation and an engagement, a fundamental human connection to get out there and do the stuff that we're doing. And I think you have seen through this particular crisis with Sharon and her colleagues in infectious disease, and many people in the health system, many people out there in the wider social debate. Of course, we don't have a vaccine at the moment. What we have is a society trying to cope with the ramifications, but preventive aspects, what we all need to do, and explanation. What we are seeing, I think, also is the importance of expertise, thankfully. The re-emergence that actually real knowledge actually matters. You can have pretend knowledge and fake knowledge and other things, but actually real knowledge has real impact. And I think, unfortunately, if that isn't shared, I must say earlier in my life, in going into clinical psychiatry, I also got very involved with people at the University of New South Wales, people like Gordon Parker and Gavin Andrews and Henry Bradati, who had a strong empirical basis to what they did, and actually a strong get out there and talk about it as well, engage with the particular sets of issues. The engagement with those most affected, and I was very glad to hear Sharon mention the HIV stage, and I must say at the time when I went into psychiatry, since my fundamental interests were not just what was inside your head, but the social context in which that took place, were some really critical things. And sadly, having lost just in recent times, both Ron Penny and David Cooper at the start of the HIV epidemic in Australia, and Australia's response was really different to the rest of the world, because that's a very strong connection between clinicians and those affected and the decisions they had to make. It was interesting to hear Anthony Fauci talk recently about the US didn't do that so good out of the National Institutes of Health and others when that started. Whereas in Australia, we did do that well, and very much that was through clinician scientist engagement with those who were most infected. And I must say, for me, that's been a model in all my life, the way that changed. I was very fortunate that my father was a professor of cardiology, but he was associated with the establishment of the National Heart Foundation at the time. It wasn't good enough to just keep building intensive cares for men of my age to die of their heart attacks. You had to change the public risk factors as well, and you had to engage with the public and in public investment. And I think that is the career path of clinician scientists in many ways. I was very fortunate to get involved, therefore, with an empirical group in an area you might not think is very empirical. But in fact, the greater the complexity, like in mental health and psychiatry and what actually goes on inside your head, the greater the need for a strong empirical tradition as well, a strong commitment to the science of the area when faced with complexity, and picking up Steve's point, when faced with the unknown unknowns, you know, some humility in the face of that to try and clarify what we can clarify and be able to say what we can say. I think what we're seeing in this crisis also is uncertainty. You know, the idea that politicians can give yes, no answers, or there is the medical advice, or there is the answer, isn't really the issue. The issue is we have a great deal of knowledge, how that can be applied, the nature of that advice, and our voice in that is very important. What we know, what we don't know, but the extent to which we actually have a perspective based in long experience about what will be possible. I was really glad to see Sharon's picture. Actually, I'll just try and change if the screen's here, if that's, I don't know if that's come up, picture of a set of twins. Does that come up on your screen? Oh, no, it hasn't. Oh. I found a set of my own twins when I went to North Carolina on a Harkness fellowship in the early 1990s. And I was very much supported by mentors in Australia to spend time overseas, go elsewhere, actually engage in other things. Now, the Harkness fellowships of the Commonwealth Fund of New York at that time were not just focused on healthcare. They were I was a healthcare fellow, but it's wider society. I was very lucky to work with groups of people in the United States and elsewhere. At that time, I'd been doing a lot of work with Andrew Lloyd and Dennis Wakefield in post-infective fatigue, stakes and immunology, talk about things that come back to haunt you 30 years later. But actually to work with the Centers for Disease Control at the time and the National Institutes of Health. And in really tricky areas where there is public debate, where there is, other sets of issues, but to engage with that and have the opportunity to work with people to say, look, getting involved also with the bigger agencies. And that was on the basis of really good work that we had done in Australia previously. So I think sometimes Australian clinical scientists and others think they're a bit remote from bits of the world. And we are at the moment, of course, a bit disconnected. But actually often the work that we do here is very significant. And we do need to take the opportunities to engage. And certainly for younger people, I was very fortunate, and with others, to strongly encourage people to look at other health systems, other experiences, other ways of seeing the world. When I was a younger student, I did spend time in the Philippines and in Southeast Asia, looking at public health in a completely different perspective in under-resourced countries and elsewhere. But getting that opportunity to see and essentially to become critical of your own system. Is it really doing the job? Is it really getting out there? Is a really critical set of ideas for us. I've been very lucky then throughout the rest of my career, returning to Australia and the academics that I've worked with, to be encouraged to take opportunities. So I had the opportunity to become the inaugural CEO of Beyond Blue, a non-government organisation, kind of an odd sort of departure for an academic, but without public awareness growth and an opportunity created by Jeff Kennett, the Victorian government, and John Howard and the national government to do something bigger, to take our field to another level, to pick up Steve's point, to build the infrastructure, in this case, public awareness of our sets of things, big set of issues. I've had the great pleasure to work with other partnerships, particularly with Pat McGorry and Origin Youth Health in Melbourne, in the establishment of Headspace subsequently. But in coming back to Sydney, largely at the invitation of Max Bennett, a professor of neuroscience at the University of Sydney, to set up the Brain and Mind Centre as a large combined clinical science and basic science centre. So we've been very lucky in that particular issue to have the support of one of our larger universities to pick it up because of the public need, because of the lack of previous infrastructure investment, and have one of our large universities invest. I must say, I've said publicly a little more than 3 times this week that the attitude of our national government to universities, I find at the moment unfathomable. Because actually in my area, it's the proof that the University of Sydney picked up the area of brain and mind sciences, psychiatry, neuroscience, mental health and neurology together. So the basic science had to work with the clinical outputs, had to look at really challenging areas in child development, in youth mental health, in aging and neurodegeneration. That required long-term public infrastructure development, and required smart people to work in collaboration, but also smart people to work with the societies and the groups who are most affected. So I'm really proud of the fact that the work we now do in autism, in youth mental health, in aging and neurodegeneration, areas that actually had not been the subject of Australia's great successes in infectious disease and immunology and other areas, but are really socially challenging. So I've been lucky over the course of my life to have actually been lost for long periods of time in the interface between the particular discipline I really care about, the mental health of, actually, I used to, when I was younger, care about the mental health of older people. As I've got older and I have visits from superannuation people all the time, I've become more and more preoccupied with the mental health of younger people and the capacity to transform that now through technology. And I'm tied up with things, including with the World Economic Forum, about the digital transformation of healthcare. We now have on our mind the mental health and well-being of 8 billion minds, and the way in which technology may transform healthcare. We may be one of the areas that is most transformed and actually reaches the developing world most rapidly through actually information technologies. And we in Australia, again, have been a hub of that, and have been very lucky through political engagement and others, through CRCs and national CREs, to engage people like our previous Prime Minister, Malcolm Turnbull, who put over $30 million of new investment into that, to say, look, that is the way to go, and to actually say to Americans and to other very important people, National Institutes of Health directors, Australia is a great hub for this. Australia is a great lab for experimentation of this. We have a coherent society. We have a national health system. We have a fundamental attitude of collaboration and can do. And to actually do things here which can be international models for ways in which things can develop. And then to be willing to share internationally. I'm very proud of a project we have in Colombia in South America at the moment to share that technology and application in real time. In my life, the worst thing that can happen in mental health is an economic recession, is a downturn, is a depression. There's a lot of discussion about war on the virus. In mental health terms, pandemics, economic downturns are not wars. In wars, in fact, societies pull together, unemployment goes down and suicide rates go down. In recessions, from the Great Depression onwards and Asian financial crisis and the global financial crisis, unemployment goes up, social dislocation happens as we're now seeing, although in this case, rather uniquely in relation to the virus as well, suicide rates go up. So suddenly, at this stage of my life, this is the worst thing that can happen, is to have such an economic and social impact of such a health crisis. And quite contrary to the kind of, in my view, ridiculous idea you do one or the other, the issue is how do we do this complex thing together? Of course, we have to contain the health crisis. Of course, we do not want to see the disaster that's happened in the Americas or in Europe. So we have to deal with that as effectively as possible. But concurrently, we've got to be smart. And so we've had to pivot a lot into working with new modelling techniques. And it's great that the words of modelling and discussion of modelling has become so marvellously, set up for us in some ways around the virus. But also, I think the modelling, the virus doesn't exist on its own. The virus doesn't have a mind of its own. The virus doesn't decide what to do. What is happening is affected by human behaviour, and it's affected by the response, what we do in advance. So I am right at the moment in the deep political argument about what really matters in this crisis to the mental health of Australians. So we have modelled what will be the disaster of the second wave or impact from the social dislocation, but that it is actionable, it's tractable. And what the government needs to do in the economic domain, which for the short speech is support JobKeeper for another 18 months, in the longer term, what it needs to do in health services, what it needs to do more broadly, but importantly, what we all need to do. The other basis of, really mental health is not really individual resilience, a concept I hate. We're all vulnerable, but societies are resilient. Social groups are resilient. What we do collectively in response. And you see great leadership and modelling in the health sector and in the research sector and in supporting each other. Australia says it does it. This is something of a test of whether we do. And also whether we are inclusive. My whole work in mental health over the years, it's about people who are marginalised by illness or by circumstances. And in these sets of circumstances, they are the ones who are most harmed. And I think it's great. We are very lucky in Australia that mental health is actually something that we are discussing every day. It's great to see the Prime Minister at the end of the week again talking about this, and the Health Minister. But we, like aged care, haven't had a functioning health system underneath it. So we're running into this crisis without the kind of infrastructure that we take for granted in the public health system and other systems. Although we have been at it for a long time, it's been a very difficult actual infrastructure to establish. So we run the risk here that the size of the crisis, the length of the crisis runs into a system that's really struggling. So there's a Productivity Commission report sitting with the Treasurer at the moment. There are other issues. So I remain every day actively involved with the media, with government, with others, not about how the sky is going to fall in, but what are we going to do in advance? What are the things that make a difference? What are the choices? And I think this is one of our critical roles. We are not, and I never say I've worked with all sorts of governments, the elected officials. We are not the representatives, but we are those who can provide advice to those who are in those critical positions, be they political leaders, be they social leaders, be they in other institutions. What is the best advice as we know it at the moment? And that will evolve. That will change. It's okay that what we say tomorrow might be slightly different the week after. The situation in Victoria, obviously being somewhat different in the last little while than previously. But I must say, at another stage of my life, when I get visited by these superannuation people who say, isn't it about time you retired, Ian? That walked off into the sunset. Go, not yet. I am one of those areas where it's as fascinating as it has ever been, where the challenge is as large as it's ever been, where the social need has ever been. And I must say one thing about being a clinician scientist, a complete lack of boredom. And the sort of enjoyment of being involved every day. I've just, with Andrew Lloyd and others this week, disappeared back into post-infective states and signaling mechanisms within the central nervous system and how they drive circadian change. And I'm fascinated with COVID-19 that suddenly people have rediscovered that there are post-infective syndromes, something that's been going on since the Spanish flu. How they affect the central nervous system, not really still sure. And the issues about what drives what and what are the signaling mechanisms. At one level, I'm as fascinated with that as I was 30 years ago. At another level, I'm tied up every day in can we get the public policy right now to save lives right now and to take actions in real time. So I think, you can only do that, as Sharon and Steve have alluded to, if you have a deep kind of science background, a deep credibility background, and you have the skills And I say just finding to partner with the people with skills. I personally don't know a lot about dynamic modelling and the mathematics that lie behind it and what needs to be done. I've been on a rapid education about that. But working with people who do has been tremendously important. Working with people in economics, working with people in other social sciences, working with people in the media, working most of all with consumer lived experience with people who are actually directly affected has been critical to the social transaction of that. So, you know, any idea of wandering off into the sunset at this stage doesn't look likely in my world. And the great thing about being in this particular area, don't really see an evidence. My great sort of role model in this is, for those who know him, Gavin Andrews was sort of forced to retire from the University of New South Wales the year before at the age of 88. He'd had his most successful publishing years between 70 and 88, you know, and was one of the most forward thinkers in terms of the use of technology, what's evidence-based medicine in our area, and going forward. So I think one of the great things, and I think earlier on people made the point, I think Sharon and others, it's a long life and a very productive one. And I think that time that it takes many directions, you can go up, you know, several rabbit holes, that's fine. People in work in this area can have some of the most productive lives. And, you know, they are productive for ourselves. They're fabulous for ourselves, but they are, and I think really reinforced right at the moment worldwide, they are incredibly important to the society that we live in, as long as we're engaged actively with that society. Thanks.
Again, thank you, Ian. Yet another insight into a passionate clinician scientist and how, in this case, he is responding to the COVID-19 pandemic and what that means. It's wonderful to see that whole passion that we see, which I think we've seen from each one of these people. I might actually, in the interest of time, go to questions for everybody, but I'll actually start with I'll just remind people, if you want to upvote some of the questions that have already been asked, please do those. There's a lot of very common ones. But I might start with Ian. Ian, one of the questions we're asked in early career decisions, how do you navigate between paths you feel you should do, like, you know, more formal study maybe, versus those you sense could be more fun, or is there a difference between them? Indeed. So how do you make those decisions?
I like the idea of Steve made it fun. I've had a great deal of fun in all of them. I think the challenge, I think the fun is the challenge. I mean, when I went off to Duke University in North Carolina as a Harkness Fellow, I took four small children there, and sort of people were like, "You got to be kidding." But a close friend of mine, a female friend, said, "You know, I'm so glad you did that. That sounds like a challenge and fun." I said, "It's the most fabulous experience of my life. Really disruptive, but great fun." And I think one of the things is a preparedness to take opportunities and to see that. So I think at times people get very overly narrow career advice. You must do this now, you must achieve this now in order, in a very linear type way. Whereas I think the opportunity, I think for Australians who are in this area, the issues of overseas experience, other perspectives outside those you've grown up with, I think is important. And I think seeing health, as Sharon alluded to and others, in a global context, you know, we're part of a global community, and seeing those differences. So, and I think Sharon's another important point. I think at different stages of people's lives, and certainly in the era I'm in, most of the people I'm very close with these days who are replacing me are younger women with families and great contributions. And that, you know, there are different times of life where you may just need to focus on different areas. But picking up point Steve made, to succeed as a clinician scientist, there are periods where you need to spend time at the deep expertise of the thing you're in. What is going to change, not now, but the future. So I think there is an issue of stepping back sometimes, and I've done this many times in my own life, from the direct clinical care, from the direct clinical service bit, to imagine the future and what is required for it.
Ian, I think this relates partly, and then I'll ask all the others too, this relates to the sort of idea about what type of research training you might need and when you do it. Steve talked about an MPH, others have done a basic science PhD or a clinical or health services type of PhD. Are there any of those better than others if you want to be a clinician scientist, or how do you work that out? Maybe Ian first and then I'll go to the others.
I'm still working on my next one. So my next one's going to be in economics. I'm under the tutelage of Alan Fellows currently in economics and others, and Craig Emerson and you know, whatever. So that's a really good question. I don't actually think it's the specific of that. I think it's the discipline associated with it. Actually, it's the thinking critically about it rather than the specifics. I mean, personally, I would have loved to have done it in immunology, or actually I turned out subsequently, I had a sort of sideways bit of my career, it's not totally gone, in brain imaging and other neuroscience type kind of sets of issues, you know, and I think any of them would have been incredibly relevant to the particular areas. And I do raise the issue about other areas like economics and other areas in the humanities. There are other areas where actually we do not have the skill set that we may need that may be relevant, particularly to health services and others. So I think for the when the clinicians are clinician trained, they've got that really basic connection with humans and the human experience. And many of these others are the disciplines that we need to partner with, and training in any one of them, as far as I'm concerned, you know, could be essential.
Sharon, do you want to comment upon that, particularly as you're a director of an institute as well?
Yeah, I think it's also a good question. I think there's probably three things to consider when you make a decision. First of all, and absolutely central, is passion about what you're doing. No, you shouldn't do research because you have to do it to get a hospital job. You should do research because you're interested about, you know, it's really a hard slog. I think Steve mentioned that. So do it in something you love. That's really important. I think when you make your decision, keep a bit of vision there. You know, where's the field going and what's the field look like now? Because in the end, you want to bring a unique contribution to the field. And if the field's dominated by one area, you know, where's your place in it? So I think always keeping your eye on the future is really good. And I think where you do it is absolutely critical. So, and that will give you the depth, technical expertise, credibility, and networks. And for me, at least, that period in New York was just transformative. I was in the absolute epicenter of HIV research at that time, with some of the best people from around the world doing their training there, all who have gone back to populate the rest of the world and maintain careers in that discipline for the next, you know, 20 years. So having been in that environment, it's hard. I think I would have struggled going from first into that. I had a bit of training first because I had my PhD before I went, and Australian training is fabulous. Anyone trained in Australia can compete with the very best of people anywhere in the world. I'm convinced of that. But anyway, I think environment's really important. You want to be doing it with someone that's extremely good at what they do.
Steve, do you want to comment upon this issue about what sort of training, when, that sort of issue again, please?
Look, I agree with all of the comments that Sharon and Ian have made. I'd emphasise that being trained is more important than what you are trained in. I think eclectic is good. I think in particular acquiring skills that allow you to stand firmly with a foot in two or more different worlds is really valuable. When you have insights in one particular world that doesn't interact much with another world, you can act as a bridge between those two worlds and make quite amazing things happen. Ian, I loved your comment about economics. That's exactly what I want to do. I've got a colleague who's an ICU physician who's got a long suit in behavioural economics, and the insights that that person brings to our team are extraordinary.
Thank you all very much there. I had a question about what about, though, if you are currently working clinically or actually, you know, coming up through that area, but you want to be involved in a research role, but when you largely unable to be affiliated with a metro research centre, what happens if you are working in regional, rural Australia, or if you maybe working internationally in a more developing environment? What are the options there? I'll go to Steve first, and then Sharon, and then Ian.
So I think that it's hard to do that in basic science. You've got to be physically linked to a lab. In clinical research and clinical trials, you can really do it from anywhere. The ANZIC's CTG never has teams associated with a clinical trial of people who all live in the same place. We were spending hours on Zoom with someone in Auckland, someone in Darwin, someone in Melbourne, and someone in Perth, long before COVID. So we've had for a long time this concept of geographically dispersed teams. Breaking into those teams is challenging if you're in a regional or remote area, but there will be groupings of clinical researchers who have that shared interest. Notwithstanding COVID, there's a vital component associated with having met people face to face. So go to the conferences, go to the research meetings, meet the people who provide leadership in your discipline, make yourself available to assist them. As a senior researcher, you are always looking for junior researchers who can run with opportunities, because there's way more than you can cope with individually. And when opportunities are given to you, make sure you nail them and deliver on them, because more opportunities will follow as a consequence of that success. And it just builds a positive feedback spiral that will allow you to establish yourself, really, I think, no matter where you are physically residing.
Thanks, Steve. Really great comments there. Sharon, do you want to add to that broader research, that series of broad questions that Steve has highlighted there?
Yeah, and I think Steve made some excellent points. I might just make the point that there's a difference between a clinician doing a bit of research and a clinician scientist. So I think every clinician should be doing research. I think it makes people better doctors and brings better outcomes for your patients. And we should hope, and hopefully everyone can contribute to some extent, but a clinician doing a bit of research is a little different to a clinician scientist. And I think that the key difference is taking a period in your career to get the training and get the depth and get the technical expertise, whether it's by experience or with formal training. It's absolutely key, because you need that, not only to have the credibility, but to eventually lead research yourself. You can't do it if you don't have the training. So if you're just talking about someone that's in a rural, remote setting and needing the training of to be a clinician scientist, I do think it's possible, as Steve said, not so in basic research, but certainly clinical research, online learning, remote contact with supervisors. I think that's all doable. But I guess the point is, for a period of your career, you do need to spend the time to immerse yourself in the discipline.
Okay. Ian, do you have additional comments to make on that area? Because your work is also very health service oriented.
Look, I think Sharon's just said a critical thing, because I spent half my life trying to, I love clinicians, they take care of me, okay? And they take care of other people. But I hear a lot of clinicians, I'd like to do a bit of research. You know, as if research is something that's kind of easy to do, they can take on. I wish they would participate in more of our research that we actually do in our area. But the clinician scientist thing is a more serious commitment. I really support what Sharon was just saying. You've got to get a skill that's very valuable. Now, we are very happy to support people who are not physically located with us. In fact, we have this happening around the world, and I'm really impressed from people from developing countries and elsewhere who join with us. But they are taking times out of their life to develop a deep skill and then apply it back in association with that. So I think that is a critical bit. And it's very hard often when people have done a lot of training and then they do clinical professional training, and then you say, guess what? You're still not trained enough to really go the next step. You really got to take time out of that when you just think you've just finally got on top of whatever the specialty is. But I think the reality is, the people I'm tied up with worldwide who are really serious about all these things, that's what they've done. They've taken time out of their own lives to build another critical skill. And in the areas I'm in, those complementary skills, I think Steve's point, you've got to have a foot in one camp very strongly, which is the clinician reality, but you've got to have a foot in the other. You've got to add some additional value. And the areas I'm in the complex neurosciences area and the complex interaction with the humanities and certainly the health services areas, we need people who bring those complementary additional skills, but they've got the real down-to-earth, grounded sense of what the clinical reality is. So I think this is a real challenge in our career development, the way we support this in our universities and our medical research sector, the way we invest in it as a nation. And I'd say Ingrid and this academy has taken a critical role in this. I think the establishment of this academy is actually really critical, you know, and the way that sits between, if you like, between academies like social sciences and science traditionally, to stay in health, it's this combination which is critical, but it's deep. The science bit is deep alongside the clinician bit if we're to succeed.
Thanks, Ian. Now, one of the questions that's been trending a bit here, which I also want to ask Ingrid about, and then I'll ask the others, is what can be practically done at the moment to support and develop future clinician scientists right now, given hundreds of early career researcher and PhD opportunities are being cut in broad areas, usually not COVID areas, but many other areas? I might ask Ingrid and then I'll go to the others.
Thanks, Louise. I think at a big picture level, there's quite a lot being done to try and develop pathways for clinician scientists. I'm not sure they're there for those people there right at the moment, but the Academy is working with a group of 8 universities to develop a pathway which should be really from where to go, from your internship, hopefully, through to being an academic. And the top 5% or so of graduates will be able to enter this pathway, which will have a research involvement along the way. It builds up to a full PhD, and then you come out the other end as a clinician scientist academic. Acknowledging that not everyone knows they want to be that from the get-go, at least we'll have a pathway, which at the moment we don't have a great pathway. For the COVID-19 situation, I think many younger researchers are really struggling, as are many older researchers, one should say. Everyone is, I think. But I think we're very acutely aware of the impact on early and mid-career researchers. And there are many different groups coming together trying to work out strategies to get through this crisis. It's going to be hard, there's no doubt about it. We heard University of Melbourne this week is going to have to let 450 people go, and I'm sure that's just the beginning for all the universities. So there is no magic fix, but I think there are a lot of people devoting their thoughts to trying to find pathways.
Do any of the other speakers want to comment specifically on that issue about strategies to support early career researchers but at this stage? What are the opportunities?
Well, I think it's important to say there are opportunities, and I think if people are headed down that path where Ingrid was headed, we need to have people engage earlier on, not sort of leave it to the end. So if you are really seriously interested, there are people who are really seriously interested. I think one of our institution's biggest obligations at the moment is, despite the national difficulty, it's supporting our best early career and mid-career researchers, and that's what we're trying to do through philanthropy, through industry, through whatever arrangements we can put together, because this is Australia's national future, and Australia has been a world leader in many, many areas of medical research of global significance. And so I think, while the current situation not so good, Australia does have intrinsically many very good institutions and a very strong track record. So I think for those people who is supporting that, and I think this is an issue of not just giving hope, but actually acting that in ways that we do support those younger researchers to hang in there at this critical time, because that is our national future. And I think the national respect for that is really high. It's just maybe not reflected in the current transactions, but the actual national respect is high. And Australia has traditionally invested in these things through its public agencies and public universities. And I think that will happen again. It's just, so hopefully this is a short-term problem in the way that it's been arranged. And I hope, as Ingrid was alluding to, many of us think we need to set up a better and clearer pathway in the future so that's better established. And hopefully this will be a stimulus to that.
Steve.
Louise, this is one of many of a cascade of long-term consequences of COVID that I don't think we yet have a handle on. I'd agree with Ian, the comments that he's just made and comments that he made it to earlier, that I think Australian society has been broadly well served by the quality of policy making during this outbreak. Not all problems have solutions, and this is a particular problem for which I don't think that there are easy solutions. What I would say is that it is true that crisis creates opportunity, and for a young clinician scientist at the moment, traditional pathways of advancement and progress are blocked or partially blocked. There'll be other options. Just try and examine them critically. Try and exert some vision about where those non-traditional pathways may take you, and look for silver linings, look for unique opportunities that might not otherwise have existed, and try and take them.
Sharon, I don't know if you want to specifically comment on that issue too about the other opportunities. I think the others have actually highlighted many of these. I think you've all made really fantastic comments there. Can I ask you as a group, this is now taking away from research training or developing, but thinking about the pandemic, from your own perspectives and fields, how do you think we're doing as an Australian society right now in dealing with this pandemic? And how has our public health system responded to this unprecedented challenge? I might go to Sharon first, and then to Ian, and then Steve.
Thanks, Louise. So overall, I think we've got lots to be proud of with the Australian response. We were quick, we were informed by evidence, we had strong leadership and united front from the premiers and the Prime Minister, and we had regular input from scientists, which I think was fantastic. We had testing widely available in the country when it wasn't in many other parts of the world. And I think, you know, the community buy-in to many of the restrictions has been great. So, you know, I'm enormously proud of what we've achieved in Australia. I think the last few weeks in Victoria have been a very kind of bruising reminder that even when things are in pretty good shape, not perfect, it has not been perfect in Victoria for a range of reasons. Even when things are in really good shape and we have a robust public health system, additional supports from around the country, and a highly functioning, hospital system, it can be extremely challenging. And I'm seeing that right now in Victoria. And so what we're asking people to do as a community is pretty significant. And then on top of it, we've got, all of the other economic impacts. So, it's been a much more testing period the last 5 weeks, perhaps not felt as acutely by those of you not living in Victoria, but felt very, very acutely by us, that it is a different period now. Having said that, I think we should be really proud. There are many good examples of countries that have done well. They have done well for different reasons. The sort of superstars, of course, New Zealand, Iceland, to some extent Korea, Taiwan, Germany, and actually look around the world, all of them are struggling with these additional second waves. And I personally, although I'm a strong advocate for aggressive suppression and potentially eradication, we will need to learn to live with COVID. We will need ongoing systems that enable us to track and trace and isolate cases until we have vaccines or treatments, effective treatments. Overall, I'd give Australia, a big strong tick, and I think we should be pretty proud of what's been achieved.
Thank you. Sharon, over to the next one. Who was that going to be? Was that Ian?
Yeah, I'll jump in. I think, look, obviously we're in a really different place to the Americas and Europe. So I think, good fortune and good enough governance has got us through the first bit, and that was going rather well. The real challenge, though, is what it reveals. So I think also it reveals what we haven't done as a country for a long time. So you can see the problems in the aged care sector. We've had these things happening in the mental health sector. There are issues about opportunities in rural and regional Australia, educationally, economically. So I think now what you see is on the health front, and perhaps this does reflect Australia having a very strong, intrinsically health system and health research and respect for actually evidence. And I think that's really been clear. Respect for evidence has actually come out in Australia, whereas that has not obviously been the case in some other places in the world to drive public policy. But underneath that, we have some real challenges. And now we're in the reality of the situation that's ongoing. Those other aspects of the society that we live in are really challenged. Some aspects of the health system, mental health and aged care, aspects of, other fundamentals around childcare, education, employment opportunities. And, as health people and people who, health occurs in a social context. We are an important part of that kind of ongoing discourse. So I think that aspect, beyond the health aspect, is going to be very challenging for Australia. Mind you, that is challenging for leaders the world over. There are no simple answers to many of these kind of sets of problems that the global community now faces.
Steve, your comments.
Look, it's a remarkable privilege to live in a COVID-free environment in Western Australia. My thoughts are very much with Sharon, clinical colleagues in Victoria. It's clear that there are big differences between countries, and the major determinant of that has been the strength of those societies to respond to the public health messaging and government policy making. The key take-home statistic for Australia is that if the United States had the response that we've been lucky enough to have in Australia, there would be 3,300 deaths in the United States, not 160,000 deaths. I think the public health response, the government response in Australia has really been outstanding. And I think there are three aspects of that that are worthy of noting, some of which have already been mentioned. But it's that policy making has integrated scientific advice and has treated scientific advice with respect. The second is I think policymakers and government have acknowledged uncertainty, and that's been very helpful in actually achieving successful messaging. And the third is that I think that our leaders have generally spoken with empathy, and that has made a big difference to the quality of response that has come from society in response to the demands that are being placed upon it.
So much, Steve. All of our speakers have really made tremendous final comments. Folk, we're right near the end of our seminar at the moment. I want to just reflect briefly. I think we've heard about the importance of either being a clinician scientist or a clinician doing research. You have those opportunities here, and please make sure at the very least that research is a big part of how you think about the clinical work that you're doing. We've highlighted the importance of following a passion, embrace your nerdy self. One of the big issues that came up was the importance of mentorship and seeking that in a variety of ways. Living a full life at the same time as you're doing your research, your clinical work, etc. You're a whole person. Don't forget to ask questions in your clinical roles. They're so important. And it's really important to be flexible on so many levels, personally, but also in terms of your work. The pandemic has highlighted how important it is to have been to be flexible, and I think our three speakers just really highlight this issue. I personally have learnt an enormous amount from hearing them talk. I want to thank you all for attending and for posting some really fantastic questions, some of which we've been able to answer in this period of time. I also now want to thank our president, Ingrid Scheffer, and hand over to her so that she can close the seminar. Thank you.
Thanks, Louise. And I'd like to thank our world-leading clinician scientists for their incredible comments. And so many of those themes resonated and were interpreted in different ways. I think it's been really useful. And as Ian highlighted, the impact of your research as a clinician scientist is on 8 billion people around the world. And I think that's one of the amazing things we can do in terms of who we can touch. I think also the respect for evidence has been really important in how Australia has dealt with the pandemic, but highlighted by good science communication. And you just heard 4 fantastic science communicators, the importance of dealing with politicians, with talking to the community, understanding social context. So I think there are many take-home messages. So warmest thanks to our 4 fellows. I'd like to thank our Academy staff who've organised this event, Ida Gambaro, and our dedicated volunteer from the University of Queensland, Chloe Yap, warmest thanks. Thanks again to our sponsors, universities of Melbourne, Queensland, New South Wales, Adelaide, and of course Monash. And we have a very short survey, I'm told, for you to complete, and the link is appearing on your screen now, I hope, and that will allow you to tell us what you thought of our first online LACS, which can go around the whole of Australia. Also, don't forget about our website, aahms.org, and there you can listen to our previous webinar, which was aimed at fellows, but welcome for all are welcome to listen on the front line. That was done a couple of months ago, but was very worthwhile. But I wanted to highlight to you our second LACS webinar as part of this year's LACS events, which is on the front line and in the lab, driving forward research in a pandemic on Thursday, 20th of August at 6 p.m. And this will feature our previous president and Australian of the Year, Professor Ian Fraser, Professor Tim Hughes, and one of our mentees, Associate Professor Asher Bowen. So this video will be online afterwards if you want to revisit some of the pearls that you've heard about. And if you'd like to know more about the Academy, I encourage you to go to our website and follow us on Twitter at AAHMS_health. Thank you very much for your involvement.